Yeah. This next video is the topic is good medical care.
Okay, you brought up an interesting subject, Michael, the opioid epidemic and what's happening to the suffering that is occurring because those chronically ill patients are not able to get the opioids or the pain medication that they need because everybody is concerned about.
Well, what happens in as with most things is the pendulum swings in one direction or the other. And so what's happening is that we're in the midst of what the government refers to as an opioid crisis. And so and there's a lot going on about that, and it has to do with more of chronic pain than acute pain. But it's spilling over into other areas, that are problematic. And so when we talk about good medical care, someone who has a very serious illness, who is either covered under palliative care or hospice, really should be allowed to receive the medicines that they need without having to go through the gauntlet. And let me explain to you what the gauntlet is that now physicians are all on notice. They risk their Drug Enforcement Administration license if they're overprescribed, or if they've given the person too much, or they've not followed.
Dies.
Well, and also if the person is not, there's not alternatives that they're looking at. There's a drug called Narcan that when it's given, it completely reverses the effects of opioids.
Yes.
And so one of the things that they did is they required that anybody that has a prescription for an opiate, that the prescription for Narcan would go with it.
Yes.
And part of the reason they did that is because if someone in the home took the medication as an overdose, or the person themselves overdosed on it, a family member could take the Narcan and administer that, and that would reverse the effects of the opiate.
Police, firemen, and paramedics are all carrying it. They've got it in schools.
Well, the reality is that it is saving lives.
Yes.
But at the end of the day, it's also causing more suffering because the persons who actually need it, who need the drug, the opiate, because that's where they are on their journey, they need the medication. And they need to not have barriers put in place for the medication. And a lot of times there's some changes in the regulations, so patients who are on hospice are exempt from having to have a Narcan prescription as well. And I don't know how all hospices have been dealing with that issue, but the one that I work with no longer prescribes the Narcan.
What about the palliative care patient? Because their situation is much longer.
Well, the thing is that a person on palliative care, in a lot of respects, should be treated the same way in terms of allowing them to have adequate pain medication for their situation.
Okay.
Now, what happens is that patients who are on palliative care get treated like anybody else. They get treated like a person who has a bad back or has injured themselves, or what it used to be is that you could get a prescription for a narcotic by a 30-day prescription, from your doctor without really them thinking at all. But actually getting back to what good medical care looks like, I want to say that the alternative to physician aid in dying or physician-assisted suicide is to make sure that people understand what good medical care looks like so they can demand it. Because that's what patients and families should be doing, is they should be demanding good medical care. Now, good medical care doesn't mean expensive care. It means someone paying attention. It means being able to go to a physician who actually understands your condition, your needs, and is able to access the systems so that you get those needs in place.
That should be a palliative care specialist.
Absolutely.
But we don't have enough of them.
No.
And if they want to group it under hospice.
Well, one of the things that I tell people this very frequently is that palliative care is separate from hospice. Hospice is the end stage version of palliative care because it's a continuum. What you and I are wanting to make sure that people understand is you should be able to receive palliative care at diagnosis.
Exactly. Michael, exactly.
So if you have someone who is concerned about your comfort at diagnosis, you're never going to get to the point where you're suffering.
Right.
And if you're not suffering, you're not asking for someone to assist you in your death, because you have decent quality of life. And so that's the point. That's the point that I've been saying all along.
Yeah.
Is,
And basically I'm saying that unfortunately right now, for the majority of people, the quality of care is not there, Michael.
No.
We do not have the bodies. If you're in a nursing home environment, no one is paying attention to you. They're feeding you, they're changing you, and they're turning you. And they can't be bothered half the time because they're understaffed. We have done a terrible, terrible disservice by not making it possible for young people to really enter the field soon enough.
Yeah.
And now we've got a shortage of everything.
Right.
So when you say quality of care, Michael, that's fine. If you can afford it, if you have got good insurance that allows you to pursue other options. But the majority right now in this country do not have those options.
Well, one of the things, just in defense of what we're dealing with currently, because we can't change the lack of people.
I know.
The thing is that you have got to educate yourself about what this looks like for you.
Yes.
Because it may be different for you than it is for other people. But at the end of the day, even people who are poor, who have Medi-Cal, Medicaid, actually can get good medical care as it relates to the issue of suffering.
If they pursue it early enough.
Well, they have to. I mean, the point of individual personal responsibility is
Rears
one
its ugly head.
that I say you've got to speak up. You have to speak up.
Yeah.
And you have to be able to understand the language to use so that you're getting what you need at the time that you need it.
Okay.
Because that's really what it is.
That's the whole reason, even in 1995, Michael, that we wrote the book. We got tired of trying one patient at a time. We got tired of seeing the suffering. We got tired of for people not having a place to go where they could gather the information. In those days it was easier to do a book. Now it has to be done online, hopefully with the blogs that'll help as well. You have got, from the moment you're diagnosed with something, you cannot turn your back and say, oh, well, I'm going to be the exception to the rule. I'm not going to whatever it is. And
I think the sad part of all of this is that a lot of times you're waiting for someone to tell you information. And I'll just blame physicians for a moment, but a lot of times physicians are waiting for you to ask the question.
And even if you do ask the question, they don't want to get into the subject. If you say, look, doc, I've got so-and-so, and how long am I going to live? They'll give you some bullshit answer because they don't really want to get into it. So you've got to be prepared to pick up this or your computer or your iPad and get the spelling of whatever it is, the information you need, and go online and be willing to sit through the trauma of listening to what is going to happen to you. That becomes an informed patient.
At the end of the day, you're in charge.
That's right.
You're in charge, and if you can't be in charge, you have got to appoint someone in your family, somebody close to you that you can have run some interference for you, because it's not going to get better. We have a gigantic population of people who are aging rather rapidly, and we don't have the bodies to take care of all those folks. We're not going to ever have enough. When we have enough is whenever this generation's gone.
Yes.
When this generation's gone, it's including me. Then
hey, I'm first.
Yeah, well, I don't see any other way around it. I think that you're going to have to advocate for yourself, and not be upset about the fact that you have to advocate for yourself.
Yeah.
You just have to do it. And if you don't have the resources,
if you've made a mistake along the way and not planned accordingly, then you've got to forgive yourself for it and just move through
exactly. Because I think that you can still get good medical care, but you're going to have to speak up louder.
Yeah.
And you may have to settle for things that might not necessarily be acceptable.
Correct.
Like, for example, people have not saved enough so that they could be in a nice, fancy assisted living.
Yeah.
If you haven't done that, or you want to stay in your home and you can't afford care, you're going to have to move.
Yeah.
There's just going to be
Yeah.
things that you're going to have to do to protect yourself.
If you're living in a house that's falling apart, that's worth $1 million, $1.5 million, unfortunately, emotionally, the decision is sell the property.
Mm-hmm.
Then those funds are going to see you through
Yeah.
whatever you need to go through. Quite often, Michael, I'm going to die in my own home. Well, that's your choice,
Right.
but it's not going to be pleasant.
No. I always love the fact that sometimes people will say, well, I'm going to die in my own bed.
Oh,
And
yeah.
the reality is that no, you're going to die in my hospital bed.
Yeah, exactly.
Because in a lot of respects, we try to honor patients' wishes, but being cared for in a 4-poster king-size bed that's elevated off the floor isn't necessarily going to be the
Well, and you need
the best
24,
bed.
20, you need 3 shifts, 7 days a week. At
Yeah, $25 an hour.
try $75 or
Oh no, well, it could be
it could be
more than-
25.
anyhow.
It could be 150. It depends on your needs.
Good medical care doesn't have to be expensive, but it can be.
Can be.